Hello everybody, my name is Marcin Malka and I present PODOS Wound Care Clinic. I am general surgeon and angiologist, and I have a plan to talk with you to discuss today about infection and biofilm in chronic wounds. First of all, the very important question, do you hear and do you see me well? If yes, write it on our chat. Yes, I see a lot of yes, so we can start. So once again, hello everyone, and we start. First of all, it's very important to how to organize our daily practice in wound care clinics, especially because we have around 25, maybe 30% of people, of patients with infected wounds. Our plan is very simple. We start with 2 hours first visit, and during these 2 hours we try to analyze what is the really cause of this wound, and we prepare the treatment plan. The next step, we need a multidisciplinary treatment team to correct care about this huge amount of patients. In this moment, it's around 300 patients in our clinic. And next step by step, we try to remove all the causes for the chronic wounds, all the barriers for correctly healing. And of course, infection is one of them. And start a local treatment is the last step. It's not the most important. The most important is the idea, the treatment plan. Okay, but today we talk about the local treatment. We talk about our fight with infection. So we should analyze this small part of this circle. This time strategy. I mean infection and inflammation. Okay. It's very important to analyze where is the moment when the infection starts. And a lot of times, I remember a lot of cases when I was late. So of course, there are a few simple signs of infection, but sometimes it's very silent, and we are not sure. We are not decide. Okay, we have to start with our antimicrobial products, with antibiotic therapy. So of course, reddening, pain, increased swarming, edema, pus exudate odor. It's simple, but it's a lot of cases when it's not so clear, and we have to decide it's infection. We have to start with this product or not. We have to wait. What about our topical treatment? About our local fight with infection? The cleansing and rinsing a wound. We use a saline. It's easy available, it's cheap, but sometimes we need something more properly, like lavaseptics with surfactant, with some antiseptics. So in Poland we have 2 possibilities, octaninin or prontosan. These products are sterile. And during the visits, we use a syringe and a small catheters. In a case of small cannulas, small caves. In a case of big cannulas, we use Nylaton catheters. They are more hard, but it's easier to rinse the bigger wounds. How you see, everything is conducted in sterile technique. Debridement. it's a very important step in our way with patients with infected wound. We try to remove all infected tissue. We have a lot of devices, a lot of tools for this part of our visits. I think that most popular are curettes because it's cheap, easy available, it's fast. Debridement, this process is very fast. Sometimes we use scissors, we use surgical knife, sponge, paddings, debridement paddings, monofilament paddings. Very interesting is our maggots therapy. In Poland we have two maggots company, and of course it's a sterile medical product, but it's not so cheap. It's around 1.5 Polish zloty per one maggot. So if you need 300 or 500, it's expensive. And VersaJet is a hydrosurgery. It's a very nice device. It's used but in all our burns department in Poland, but it's maybe at this moment too expensive, the sterile probes for using in a small outpatient clinic. And according to this case, you can observe the biofilm and the necrotic tissue and on the first picture, and the same visit, June 27th, yes, and this is a few minutes later. So it was debrided, and now there is half of the wound bed is covered by granulation tissue, and 3 days later there is no necrotic tissue, there is no visible biofilm, and 1 month later it's good for epithelialization, and a few months later it's closed. So there was a sign of infection because biofilm is one of the signs of infection, but now it's a few days later it was broken. And I know it's very popular that cleansing is not the same like the contamination, but I have a lot of workshops, a lot of webinars, and I know that some people have a problem with this process. What is the cleansing? What is the debridement? Where we have to use some products? So when we start with fight against the infection, we try to use the antiseptics, the contamination product. And we have not so many products on the market. At this moment, we have only 2 sterile products. And to be honest, it is lavaseptic. It's not an antiseptic, but it's only 2 products which are really sterile. So it's safe to put it to the wounds, especially to the deep wounds. And we have a lot of non-sterile products. And of course we use all of them, but I think it will be changed step by step in our government regulation. At this moment we have hypochloran product, we have PVP iodine, and we have octanine product and PHMB product, and it's good for superficial wound, but you have to decide. I use this product for rinsing the deep wound, but I know it's not sterile, so it's still complicated. It's very important to know that this 2 product is forbidden to rinse deep wounds because it's to the infected wounds, but it's dedicated for infected wounds, but superficial. So we start with this product at the first visits, and yes, it's these 2 products are sterile. And what you see on the pictures, we need some soak phase. So every of this product has a special guideline, and you have to know how long should be this soak phase. 5 minutes, 10 minutes, or in case of PHMB, 30 minutes. So it's very hard to use this product in the outpatient clinic because sometimes we have only 1 hour or 1.5 but I know a lot of places when we have only 15 minutes for each patient, so it's impossible to correctly decontaminate wounds with this product. Okay, and we have also a lot of dressing on the market in Poland. Most of them are reimbursed by our government, and there are a big part of product with silver. There is a lot of kind of silver. We have big molecule, we have nanocrystallic silver, sulfasalazine, and metallic. So it's complicated. Which product is the best? We use all of them, but we know that for some situation we need a special product, better product, and we try to decide which product will be the best for this kind of wound. And we have only 2 products with iodine. My favorite is Iodosorb, because Iodosorb, it's only one iodine product with cadoxamer iodine. It's a kind of polymer, and in this product the iodine is put to the wound very slowly. So it is the same when we use an antibiotic therapy. We need not only one shot, we need a lot of dose step by step, and it's better for remove the biofilm, for promote the good healing. And I appreciate for Smith and Nephew company because the possibility to talk today, to meet with you, and I decided to choose 2 products of this company to describe you how it works. Maybe some of this information will be connected with my experience, because I work with this product from more than 10 years. The first one is Iodosorb. In our clinic, because there are 3 kinds of this product, but this one is, in my opinion, very useful, especially for small or superficial infected wounds. In case of Pseudomonas, and when we decide maybe it's not a good time, it's not a spreading infection, we have to wait a few visits, we're afraid to introduce the antibiotics. And I have a lot of cases when we decide, okay, the antibiotics are not necessary because we have a good local treatment. So Iodosorb is released to the wound bed by 3 days. It has a small possibility to catch this exudate, and it's also having the possibility to destroy the rest of the biofilm, because when we debride, for example, biofilm with curette, and we get a very good quality picture. Now we have 48 megapixel of our picture has very good quality, 48 megapixel, and when we wide this picture, we can observe, okay, I thought that it's debrided, but in reality it's not a good conduct, because there is a lot of small pieces of biofilm. So it helps to fight with biofilm between the visits. And I show you a small video. The first one is about the properly cleansing or lavaseptic. It's one of our patients with venous leg ulcer, and cleansing is not it's not a short activity. It's we need 5 minutes or more for cleanse the wound and the bright. These wounds are not very very infected. You can observe the granulation tissue, but in okay, and but it should be debrided during every visit. And the iodosorb application, it was received yesterday. The patients after a sarcoma and foot sarcoma and after surgery, and there was very around 5 millimeter of deep of biofilm. So we used 2 pieces of this smaller iodosorb, and I'm sure that after few application of this product and properly working with this wound during each of visit, because in our clinic every visit is realized in the clinic, so we try to stop this patient activity with wounds, because it's not so successful, it's not so fast, and of course it's connected with possibility of the patient. And this is my system for the smaller small venous leg ulcers. I hope it will be eradicated in a few years in Poland, because it's the easier it's the easiest wound, the chronic wounds from our almost 500,000 of patients with chronic wounds. So I hope it will be eradicated. We need only a proper topical treatment and compression. So this kit, iodosorb, some foam or super absorbent, it's Alevin Life non-bordered, and compression. This is the multi-component system. Profore is the ideal kit for the small venous leg ulcers, and the dressing changing is possible to be conduct every 7 days. Of course, in case of infection, we need to do it more often, but at the some moment, it's possible to meet with the patients one weekly. And the second product of this company is Acticoat Flex. I think it's more than 10 years on the market, and at this moment it's only one product in Poland with nano crystallic silver. It's very open structure, so it's good for the first layer. Some multi-layer dressings. It's possible to easy transfer pus or some heavy exudate in case of circular venous leg ulcer by this product to the super absorbent, to the negative pressure foam or some another products with high capacity. It's also a good product for cetonage, for drainage. When I hope you use this system of closing of chronic wounds. I mean a steri strip or leuco strip or some kind of strips. And when there are some risk with infection after closing wound, we put some cetons from Acticoat, and it's impossible it's easy to evacuate this drainage from the wound. And it's also very stretched, so very flexible and very stretched, so it's easy to easy for application to the complicated the wound which are complicated. And a few words about infection, because of course you know that every chronic wound has the cause of contamination. So when you analyze, when you put some swab for culture from chronic wounds, I'm sure that there will be some microbes in this analysis, but of course it's not a problem. In almost all cases there is no problem with the healing process. The same in case of colonization. There is a red granulation tissue, there is no sign of infection, and we don't need a product, antimicrobial product, and we really don't use this product and this moment, because it's not necessary. But in case of local infection, we have to start with, when we have a sign of local infection, we have to start with some antimicrobial processes and antimicrobial products. So debridement, cleansing, rinsing the wound, using lavaseptic, using antiseptic, using antimicrobial dressings, and from time to time antibiotic therapy. But we start with antibiotics not when we have a sign of local infection. When we have a sign of local infection, we start with a very carefully topical treatment. We spend a lot of time with patients. We realize the visits 3 times weekly, and we try to catch it at the beginning. But when we have a spreading infection, when the infection is spread, we have to start with antibiotics. So we take the deep tissue biopsy. I show you how we organize it. Sorry. Okay. This we need after cleansing the wound, we take the new curette, and we take the healthy tissue, and we transport this part of tissue to the probe, and we have 24 hours for starting with this examine, and after 5 days we have the antibiogram, and we know exactly what kind of antibiotic we have to use. Of course, sometimes we need to start with empiric antibiotic therapy. So we use a lot of guidelines, but to be honest, we have no good guidelines at this moment. We have the guidelines from US, and of course it's another kind of bacteria in Alaska or California than in Poland or in other countries of Central and East Europe. So we need a new papers. And step by step, how to take this deep tissue biopsy, because the superficial swab, in our opinion, and of course there are a lot of public papers on the internet, the deep tissue biopsy is of course have a good quality, and there is a lot of cases then superficial swab show that there is nothing, or very easy to kill microbes. But when we take a deep tissue biopsy, we observe, oh, there is MRSA or something like this. So in my opinion, it's better. So we have to clean the wound with saline. We don't use antiseptics or lava septics with some antiseptics during only on this visit when we want to take some deep tissue biopsy. Next, we remove that tissue with some device, some tools. Almost in all cases, it will be curette, and we try to take not a pus, not a fibrous or something necrotic tissue. We have to take the live tissue from the most suspected of infection place of the wound. Sometimes we need 3, 5, or 6 probes from one patient, and only 2 or 3 are positive. So it's important to take more than one probe from biopsy from one patient, and we use a sterile technique to transfer this collected material from the curette to the swab, and after 5 days we have the answer what was the cause of this infection. And how it looks at our clinic, how we organize these visits step by step. It's very strange for me, but there is no a good books, no good publication about this simple steps. How we have to organize it during our daily practice, how to do it, how many time I need to spend for the debridement, for the cleansing, and we start with our clinic 8 years ago. Now we have 50 employees, so almost 20,000 visits conducted every year. So I know exactly how it looks step by step. So I'm happy to talk to you about this activity. We start with taking over the product, the compression system, the dressings, and we wash the peri-wound skin because every visit is serialized in clinic, so it's impossible to conduct this process by patient home. The next step is conducted in a sterile technique. So we prepare sterile drops. We use a sterile gloves, yes, and we clean the peri-wound skin with some alcohol liquid, and we use sterile drops with glue to protect the wound from the peri-wound skin, and we work between sterile mail table and between the wound, which of course is not sterile, but we are sure that we border this wound from the patient and clinic environment. Okay, the next step, cleansing, rinsing, using the catheters. Every small cannulas, every small case should be rinsed correctly, and it spends, I don't know, sometimes a lot of times, because in case of big pressure ulcers and complicated diabetic foot syndrome cases, we need a lot of saline on another lava septic. Debridement, it should be realized according to the UMA documents, debridement documents from 2013. This process should be conducted in a sterile technique. And I have one question. Do you clean the wound with only saline solution? No. We use also another lava septic. Especially in case of infection, we use another product, but it's not so many this kind of product on the market. So at this moment we have only two products, octanilin and prontosan, and they're of course more expensive than saline. So in most of cases we use saline, but with case of infection we use also octanilin and prontosan. There will be a 5 or 10 minutes and end of my presentation for question and answer. Answers, and I continue. And do you remember about the soak phase? Soak phase. According to the guidelines, every antiseptic has another guideline. So we have to know exactly. Okay, this product needs 5 minutes for the correctly decontamination of wound bed. So 2 is too small, and I hurry up. Okay, so I use another product, or I try to realize and to conduct next visit by not 30 minutes. Maybe I need 1 hour, but you have to know how it products works. And photo documentation. Now we use a very good quality smartphones, so the pictures are very good, and we also use sterile rollers for measurement of the wounds area. And the next step, it's the last step of our visits. It's the dressings application. In case of infected wound, we use antimicrobial dressings. I said that this kind of product, almost all of them are reimbursed, so it's easy to buy it by patient. And according to the amount of exudate, we have to decide what kind of secondary dressing we use. It should be super absorbent, like on this picture, or we have to choose some foam, thin foam. There are a lot of products. And the last step is the some added therapy. It will be, for example, compression therapy or offloading or another techniques in another kinds of wounds. And I prepared a few cases for you. Patients with infected wounds. The first one, it's a 33-year-old man with venous leg ulcer on both legs for 12 years. So it's very strange that this man never listened about the compression therapy. So of course it's a reason that there was no result for this problem. And we start with during the first visit with analysis with ankle. We perform ankle brachial index, toe brachial index, a lot of examines, and during our topical treatments with the bride cleans the wound. The bride use the antimicrobial product. This is the iodosorb dressings, and the foam, non-adherent because we had a plan to use. We had a plan to use a compression, and it's better to use no adhesive product under the compression, especially when the wound is infected. And after a few visits, there is a granulation tissue because the debridement with curette was repeated on each visit. And after a few visits, you observe the epithelialization, and 2.5 months for closing this kind of wounds. It's maybe not so best result in our clinic, because we try to close the venous leg ulcer in 2 months, but it depends from the patients, from the compliance with these patients, and sometimes more than 2 months. And the second case, it's 7 years old man with Charcot osteoarthropathy. On the X-ray picture, you can observe completely devastated the ankle joint, and of course there is a wound on the plantar part of the foot, and the sign of infection, the biofilm. And after debridement, we use the contact layer, antimicrobial contact layer. It was actually called Flex 3. And we decided to use the adhesive product because there was not so many exudate, but we had to construct the total contact cast, and it's better to catch the exudate in the dressings in case of using of total contact cast. But sometimes it's not available, so we have to decide. At this moment, it was good to choose. So after 181 days, so almost half a year for closing this easy wound, but Charcot osteoarthropathy, 150, the weight of the patient 160 kilograms, a problem with offloading. So it's a real problem in case of Charcot and obesity. And the orthosis after closing the wound, the Crow orthosis, it is produced by some company from Warsaw, and we cooperate. It's the Crow Charcot Restain orthotic walker. Very good orthosis for save this limb before recurrent of this wound, because before the recurrence of Charcot, and we use this orthosis sometimes by 6 months, 12 months, a lot of time. Very complicated case. 38 years old woman with diabetic mellitus type 1. And during pancreas and kidney transplantation, there was a pressure ulcer connected with neuropathy, and it was infected. And unfortunately, there was no correctly offloading. So during the first visit, we observed the fracture of the heel bone. So this part of this bone was infected. Very complicated case. And of course, because there was a long hospitalization, we have alarm pathogens in the wounds, and we have to use the intravenous antibiotic therapy by 3 or 4 weeks. And after very hard topical treatment, a lot of time we need for debridement, for catch this infection, and we lost 4 toes. And you can observe on these pictures that we use the maggots, we use negative pressure wound therapy, and when we prepare the wound for the skin graft, we decide for skin graft. This procedure is conducted in outpatient clinic in our clinic. So 5 months, so very long, almost half a year for closing this wound. And the same patient, but the heel area, it was more complicated because this part of this heel bone was broken, and we have to remove it. And step by step, it looked better, and we tried to close it under vacuum control. And February on February 29th so it was 5 months for finish our healing process. Next patient, 60 years woman with Charcot osteopathy, and of course you can observe the signs of infection, maceration of the skin, caves, cannulas, very hot peri-wound skin, the odor, a lot of pus inside this cannulas. Because there was some place under the plantar part of this foot, and of course devastated the ankle joint. So it was not so. We are not so sure that it will be possible to save this limb before the amputation, but step by step we try to do it, and we are succeed. And about a few words about local fight with infection. The same, cleansing, rinsing, repeat this procedure every visit 2 times weekly, using antimicrobial products, slowly closing the wound, very slowly, because we remember there is still a few signs of infection. And negative pressure for preparing the wound for graft or for closing, and of course all the time total contact cast. You can observe how it looks on the X-ray examine, and it's the follow-up after a few months. So we have 8 months between the first and the last picture, and you can observe completely another ankle joint. So it's easy to it's not so easy to conduct patients by this way, but in case of good compliance with patient, it is possible. Okay, we have 70 minutes. It's a trick how to connect compression negative pressure wound therapy with total contact cast. We have to build the bridge, for example, on the plantar area, and put the port on the frontal, on the forefoot, sometimes on the toes. And next we construct the total contact cast. So it spends 1.5 hours every visit or more. Okay, the next patient, 73 years old man with neuropathic diabetic foot syndrome and with spreading infection. There was taking the vein for the coronary artery bypass, and after this surgery there was a surgical site infection, and the patient was admitted to our outpatient clinic with this sign, but we observed the redness on all the foot. We observed the spreading infection. So the deep tissue biopsy and very fast topical antimicrobial treatment. And after the debridement, we unfortunately lost a lot of tissue. And from the small wound, we have a very deep, very complicated wound of dorsal part of the feet. So after finishing the infection part, we start with negative pressure, and we prepare this wound for skin graft, and it also was conducted in outpatient clinic. We use a sterile silicone net foam, and 7 days later we observed that this graft was accepted. And the last one case, 41 years old woman with very seriously infection of the heel area. It was MRSA infection, so I was very afraid about this heel, and we decided to use a wheelchair all the treatment period, and intravenous antibiotic therapy, antimicrobial dressings, and next negative pressure skin graft. Is the same plan for a lot of patients, and 4.5 months for closing. And of course, it's impossible to use a normal shoes in case of this kind of graft, but now we have a lot of very good quality shoes on the market with very soft insole and very good shoes, so it's easier than, for example, 5 or 10 years ago when there was no good shoes on the market. And a few words about our team. At this moment, we have 6 doctors, 23 nurses, 2 physiotherapists, 3 podologists, 1 dietitian, very important person in our clinic. We work in 6 treatment rooms on 2 shifts. We have also 2 podological rooms, so the podologists in PODOS in Poland don't take care about patients with wounds, but it's good for the prevention of recurrence, the education patients, take care about some cosmetic problem on a foot. And last year we conducted almost 20,000 visits and almost 900 negative pressure dressings application. We work with 23 devices, negative pressure devices. All of them are in outpatient basis, and we love compression therapy because almost 20,000 visits and more than 5,000 compression therapy application. So every 4 patients has a compression therapy. So it's very popular and very necessary in case of edema, in case of venous insufficiency. And all together we create a multidisciplinary treatment team. Okay, we have 12 minutes to the finish of our meeting, so I'm happy because we have enough time for a small home message for you. First of all, for me, the most important is education. So I remember my first cases of patients with infected diabetic foot syndrome in hospital 70-60 years ago. I lost a lot of patients because I have no idea how to take the probe, the swab for the culture. I have no idea how to use properly antimicrobial products. Now we have a lot of products on the market. We have a knowledge. We have a lot of papers, and it's easier to fight with infection. And my daily activity is not only working with patients. I spend a lot of time for education because I know how important is it. So we organize the workshop, conference, webinars. Now in the COVID pandemic time, it's closed. But I hope that after this period we will meet all together on some wound care conference in Poland or maybe in your countries. Sterile techniques, of course, it's not necessary according to EUMA guidelines, but to be honest, in our clinic, every dressing changing is conducted in sterile technique. Why? Of course, it's more expensive than clean technique, but we are sure that we resolve this problem, and we have very small percentage of recurrence of infection during the healing process. Proper culture technique. I decide to choose the deep tissue biopsy, microbiological biopsy, and I'm sure that it's better than taking the culture for the swab. Antimicrobial dressings. We have a lot of modern antimicrobial dressing on the market. I'm happy because a big part of it is reimbursed in my country. So it's easy available for our patients. Some of them are not reimbursed, but we use it, of course, because we need it. And it's important because during the visits we do a lot of antimicrobial procedures, but between the visits there is nothing. So antimicrobial products to continue our activity between the visits. And what is important to create a new multidisciplinary treatment teams in your countries, in your clinics. Maybe it will be private, maybe it will be government, it doesn't matter. It's important to be not alone, to be with another doctors, with another nurses. It's very easy to take care about so huge amount of patients when we have 50 employees. Yes, when I was alone, it was very difficult to resolve some leak in case of negative pressure or something like this in the middle of the night. So now it's very comfortable for me. And now is a short time for question and answers. So I try to resolve all of your questions. Okay. Greetings from Kosovo. Hello, Kosovo. It's a very nice country and very friendly people. So I spend a lot of nice moments in Kosovo during the Kosovo Wound Care Conference. And did you use VAC? Yes, we use 23 devices at this moment. All of them are working in outpatient clinic because we are outpatient. And it's not reimbursed in my country, but it's necessary, so patients have to pay for it. But I don't know how to resolve some problems without negative pressure. I think it's impossible. For example, a very big pressure ulcer or very complicated diabetic foot syndrome. By VAC, do you mean negative pressure? Yes, of course. Negative pressure or vacuum assisted closure, there are synonyms. Do you clean the wound with only saline? I answered for this question. We use another lavaseptics, but saline is easy available, is cheap, and for not heavy infected cases of no heavy infected wounds, we use a saline. What kind of anesthesia did you use in this case? I don't know which case, Anton, sorry, but we talk a lot of times about anesthesia in PODOS. So we start with oral drugs and painkillers, also with morphine 15 minutes before sublingual, before visits. We use lignocaine gel, sterile gel on the wound surface, and we have to wait 5 to 10 minutes and after it, it's time for debridement. We also every of our doctors knows this original anesthesia procedures, so we use Ober's technique and near the ankle technique, and sometimes it should be repeated on each visit. So we have a lot of techniques, but sometimes we have also problem with pain. So from 2 or 3 years we use a nitro oxide, some gauze for breathing with this product, and after few breaths you feel something like under alcohol, and it helps to clean the wounds, to debride the wounds, and sometimes we gave the patients the intravenous painkiller. So it's all of our techniques. It's difficult to organize. It's some higher regional anesthesia in outpatient clinic is forbidden in Poland. What time do you keep iodosorb application on, and what is the time of such therapy? We change the dressing in case of iodosorb using. We change the dressing every 2 or 3 days. Almost often it's 3 days, but it depends from the exudate. But how long I use a iodosorb? Sometimes it's only one case. For example, venous leg ulcer, a small sign of infection, and after one using, it's a granulation tissue. Sometimes very complicated diabetic foot syndrome, very big problem, and I use during the lot of visits. I remember a lot of cases when I have to start with antibiotic therapy, but I try to resolve it with topical treatment, and I will succeed. So I know that this border between antibiotic therapy and a good modern antimicrobial dressings and correct antimicrobial processes during the visits is movable, and step by step we are more brave in our activity. What is the reason not to use adhesive dressing under compression? It's not my idea. When you try to cover a wound with a lot of part of padding, a lot of part of multi-component compression, and there is also adhesive foil on the wounds, there is very wet environment, wound environment, and sometimes it's a good for promoting the infection. So it's a very regular activity that we use non-adhesive product. Compare it, one visit with adhesive and one without. You will observe that this case in without adhesive dressing under the compression will be better kind of skin, better kind of wound bed tissue. What is the reason? Okay, do you know something about evidence that negative can help us to remove the biofilm from the wound? There is very good human document about negative pressure, and of course you observe that when we remove the foam from the big wound applied with negative pressure, we observe that the granulation tissue is very red. Sometimes there is a bleeding, and when there is a small part of the wound without foam, we observe the biofilm on this part, and under the foam there is no biofilm. So we know that it's a good device for destroy the biofilm, but of course the most important is our activity during the visit. It's impossible to treat the patients applying some products and do nothing during the visits, just clean the wound and put another product. So our activity, our hands are very important. So it's the reason that we have 23 nurses in our clinic. Hello from Romania. Hello. I have a lot of friends on all the world, I see. What do you think about local usage of antibiotic into deep wounds? The answer is not so complicated because it's forbidden in Poland, and it's also forbidden in European Union according to EUMA guidelines. So we don't do it. The only one case when we have the possibility to use a local antibiotic is one product, garamycin. It's a sponge with gentamicin, and we of course use this product in case of some complicated infected wounds. And we have we need some more than only topical treatment. We need some antibiotics, but unfortunately there is only possibility to give intravenous antibiotic, and the patient has no possibility to come to clinic every 6 or 12 hours, or for example there is no possibility to buy this antibiotic because ambulatory outpatient antibiotic therapy is not reimbursed in Poland. So garamycin, yes. Another product, no. Do you use also a Pico? Yes, of course we know this product. The first application, my application, was in 2011, so it was almost 10 years ago. And I know this product very good, and I had a lot of cases, very nice cases. So I believe that maybe during the next meeting it will be a good moment for divide with you with these cases. Greeting from Spain. In this case, we apply Eurosorb or Acticoat. Oh, sorry, unfortunately, I don't know in which case do you mean. Eurosorb is good for superficial wound, maybe 2-3 centimeter. It's not good for cannulas. It's not good for deep wounds, because we have to drainage this exudate from the wound. So in this case, I use Acticoat because it's good for prepare some small pieces and put it to the deep cannula. And Acticoat is also better for the bigger wound because it's cheaper than Eurosorb. If you take one Eurosorb, it's good for a small one. If you have to cover a circle venous leg ulcer, you need a lot of Eurosorb and only 1 or 2 pieces of Acticoat. So it depends what products are reimbursed in your country, what is the price of the product, and of course it's impossible to use only one of it because some cases are impossible to apply with Eurosorb, and some cases it's impossible to apply with Acticoat. So in our clinic we have a lot of antimicrobial products, and every employee has the possibility. Every employee has a possibility to choose which one will be the best. Hydrogen peroxide, no. For the chronic wounds, it was forbidden in my country in 2009. I thought, and it's good for the not non-chronic wounds, but it's not good for the chronic wounds because it's cytotoxic, and we have to promote the epithelialization, granulation, and hydrogen peroxide. Maybe it's good for fight with infection, but we have to remember that we need a macrophages, we need a granulocytes, and this product kills this cells. So we use another product. Victor, best wishes from Ukraine. Hello, Victor. I mean, how do you decide when do you choose your server Acticoat? So I translate you that it's not so complicated. In deep wound, I choose the Acticoat. In superficial, it will be better to use Yadasor in case of infection, of course. Hello from Brazil. Hello, so long distance. Thanks for the presentation. It was great. Thank you, Aldurlane. It's possible to use silver dressing against biofilm. Yes, there are a few products. But do you remember that silver kills the microbes? And if you want to remove the biofilm, you have to prepare the wound for activity of this product, because silver is good for planktonic bacterial. But in the biofilm, there are a lot of barriers to destroy it. So the best solution will be remove the biofilm with some, for example, curette. Very preciously, we change the curettes during the visit, and small and small for the every small cannulas, every small case, and after it, we use the antiseptics, we use the contamination of the wound surface, and after it, we apply the silver. In case of Acticoat, we have to cleanse the wound with sterile water, because there's some problem. It's very good quality of silver, but it's easy to destroy with saline. So we have to choose the sterile water just before putting the Acticoat. Do you use shave therapy and autodermoplastic? No. It was popular in venous leg ulcer, especially in circular venous leg ulcer a few years ago. Now we don't conduct this kind of surgery. Why? Because we have another devices, another techniques, and at this moment we need only 2 months or 2.5. My best case is 42 days for completely closing circular venous leg ulcer. So we use negative pressure wound therapy and skin graft, outpatient skin graft, and with applying negative pressure just after this procedure, and of course compression therapy. And this technique is very fast, and shave operation was we need a operating theater, we need more money, so I think it's a good idea, but now we have better. The last question. You put another product with Pico. Sometimes we use silver, especially for drainage, and we can put some filler to the wound under the Pico. There are a special foam dedicated for the Pico system, and sometimes I have a few cases when there was a deep wound, because the Pico have the possibility to be applied for the wounds not deeper than 7 centimeters, and sometimes we use a sponge foam to fill this wound, and next we apply the Pico. Farina from Kosovo. Hello, greetings from Poland. Thank you very much, Dr. Malka. Greetings from Estonia. Wow. And our last activity will be the small question to you. If you have 3 or 4 minutes, it will be a pleasure to know what was your opinion about our webinar. You are interested in our activity. You are interested in next webinars. So if you have the few minutes for me, we can write this webinar feedback form. I don't observe any activity. Sorry, some problem. Sorry. Okay. And what's wrong? We have some problem with our survey summary. Give me one moment for connect with our techniques. Java, okay, it works. So I'm not sure that I cannot write there. Okay, some problems. I don't know why. Every works correctly, but now we have some. How does it work? It's not possible to write. Give me a few minutes. So we have some problem with this. I try to start it another time. Okay, try again. Okay, now it works correctly, but because I see some answers. Try to. We have 38 participants at this moment, and I observe your answers. Thank you very much for your time. 1 minute for end our voting. If you have some question at this moment, it's good time for answers. I hope that these answers will help us to organize the next webinar. Maybe there are more interesting subjects for you. We have some question. No, thank you for presentation, Maria. Thank you, Maria, for your visit our webinar. %44% of participants vote, and it will be a pleasure to know what was your opinion about our activity, our webinar. So I hope it was enough time for voting. So I end and I show you the result. So almost all of you was satisfied, so I'm happy. And we finished our webinar. So thank you for giving me 1 hour of your time. I appreciate the Smith and Nephew company for organization of possibility of organization today's webinar, and I hope it was you enjoy and you are happy because this activity. If yes, I try to organize next webinar. So best regards from Poland, from my home. Bye bye.